Well, what an honor. How exciting to be recognized in this manner. And I want to thank Cardinal Health Foundation, the Foundation of Cardinal Health, ASHP Foundation, and all the surveyors and reviewers for reading all those stacks of papers. Kind of suckered us in with a little one-page application, one-page abstract that led to a 10-page application and led to an all-day visit. And so, but it was well worth it. And the recognition from outside of our hospital system is very exciting. And I also want to congratulate all the other award winners. After watching your videos, we're very fortunate to be in the position that we're in. We all did a very important work. I also want to acknowledge our leaders, as it talked about in the video. This started with a vision from our quality center, our white paper that was written by my boss's boss, Clay Dunnigan, and Steve Lipstein, and approved by the board. He's the CEO of BJC, to challenge us to reduce preventable harm. We also had an executive sponsor, Dr. Credit, who you saw talk earlier. He started us off with, we don't know what we don't know. We didn't know what our preventable harm burden was. We didn't know what caused it. We had a group of pharmacists and everybody had a different opinion, and so he challenged us to discover what the problem was before we started going out willy-nilly and attacking things. So we also had great leadership from a coordinating committee, and I have several of them here. I want to recognize Tom Hall, and if you just want to raise your hands, Tom Hall, Christine Pavlak, Tony Kessels, and Rich Reichley. We're all on our coordinating committee, giving us a lot of veteran guidance onto the directions that we were headed and advice on how to get there. There was also one of our endocrinologists, Gary Tobin, who you saw talk there, who was from our academic hospital, and from Washington University, who was also very helpful and key contributor to our efforts there. So that was the vision and the leadership and the opportunity. I want to just thank BJC for giving me the opportunity to be able to lead this team and be the clinical lead for it. As much of an honor as this is to be recognized for this award, is an equal honor to be able to work with the people and the clinicians and the leadership that I got to work with at BJC. So I don't want to forget our multidisciplinary team. This happens to be a group of pharmacists who are here today, but since it looks like you're videoing this, there's a lot of nurses and diabetic educators who are going to be watching this video online someday soon. And unfortunately, they're not here, but they will be presenting with us this summer at the annual meeting in Las Vegas this summer, and I'll be sharing the podium with them, so you'll get a nurse's perspective and diabetic educator's perspective as well. Along with the task force, wasn't all nurses and diabetic educators. We do have several of the other pharmacy members here. So Emily Michelson is at the table here, Kathy Vogt, and Jennifer Reynolds, there she is over there. They've all been members of our team for quite some time, of the task force that worked on this. And then last but not least, a lot of this was driven by informatics, and so I have two informatic pharmacists here, Nick Hampton and Tim Holman. They're sitting side by side. They can't get too far apart. We don't let them travel together. I don't know how you guys got on the same airplane. Because they played key roles in some of the dosing rules and clinical decision support that we did, and so very important as well. So I wanted to talk just briefly about some of the keys to our success. So one of them was our broad leadership. We did, besides the leaders here, this was, and you saw the CNOs, and I think this came across in our site visit, that this was a intervention and a project that was shared by all of the leadership across the hospital. And I think an example of that would be, Steve Lipstein is the CEO of our system, and I was on a bicycle ride with him, MS-150 bike ride, and he was there at the tent afterwards, and kind of knows me a little bit. I went up and said hello, and he started introducing me to a few physicians, and then he said, do you know Paul Milligan? Well, they had no idea who I was, but he said, looked at me and he said, let me see if I get this right. He said, so Paul Milligan used to be a pharmacist. I didn't correct him. Still am. He said, but now he works for Clay Dunnigan in the quality department at BJC. And he looks at me again and he's like, okay, so I'm going to try. He said, so he just became a finalist in a national award before leading an effort to reduce hypoglycemia across our system, and they had a big impact, and it was really crucial work that the team did. And he said, how did I do? And winked at me, and I was like, yeah, you made my year. So, so that was the CEO of a 12 hospital system. So even from the top to down to the clinical, to the nursing charge nurses, and this was something that flooded our healthcare system, and they knew about it. So raising awareness of hypoglycemia as our #1 event was key to our success there. So the second thing was we had access to exceptional clinicians. You never know where you're going to find excellence, and we happen to have 11 other hospitals where we could go ask help. I worked at the system level, but I knew pharmacy directors and clinicians at all these other hospitals. So we were able to discover best practices in a lot of different areas across the system, and you never know where you're going to find it. You wouldn't, I was telling them at the table a little while ago, we wouldn't think children don't have hypoglycemia very often, but yet at St. Louis Children's Hospital we found our surveillance system, which was an automated surveillance system that they pioneered at their hospital that we brought in and used at our hospital too. So we found excellence everywhere, and so it was a nice benefit to be able to pull from 12 hospitals or 11 hospitals. Sorry to get this number mixed up. Also, we were lucky enough, or I was at least, at the Center for Clinical Excellence where I work for BJC, to leverage all of the resources that we had there. We have access to informatics, like I was talking about. We have an analytics department, we have epidemiologists, we have a transformation support group that tells us how to affect change in a large, complicated system easily. And we have a clinical advisory group where we have nurses and other pharmacists to ask questions about. The fourth key to our success, I think, was the fact that we measured things very well. We had a very good way to identify hypoglycemia events. And they always say what gets measured gets managed. And because we had such a valid way to measure things, we were able to add it to our system-wide scorecards, which are incented so that raises awareness amongst hospital leaders if they're those type of scorecards. And then also we found out why the events were occurring. So we alluded to that at the very beginning about how we investigated each event and came up with what the causative factor was for each event, so that we could be good stewards of our resources that we had. So we didn't just go out applying best practices at all of our hospitals. We focused like a laser beam at each hospital. So lastly, none of that would have happened. None of this would have been successful without the relentless groundwork that was done by our hypoglycemia task force, the pharmacists here, the nurses there that aren't here right now. And so they had to take the information that we gave them and implement it at their hospital and fix the problem. One of the reasons that the extent of severe hypoglycemia was a surprise to us is it's kind of a hidden epidemic. I don't think it was on our radar or anyone's radar that it was going to be 70% of our adverse drug events. It's treated with apple juice, for goodness sakes. I mean, it's not something that is on the radar. I think doctors may undervalue the severity of that and sometimes forget about the fact that discount the fact that those events occur. But what they don't forget, and what the points that we've made since then, is that when we first started this, we had about 5 events per month across our system. And we actually, last month, we had 1 event, exactly. We had 31, it was our 31 days in November. We had 31 events in November, instead of 140 or so is what we had been having before. So we're actually building steam, and rather than leveling off there. But even at, say we've reduced 3 events, so they may forget about the severity of hypoglycemia, but they don't forget that we can tell them now that there's 3 fewer patients per day experiencing confusion. There's 3 fewer patients a day who might even be being unconscious and creating some other risk factors for falls and aspiration. So they don't forget that. They don't forget that there are 3 fewer patients per day put at risk for chronic brain injury that could interfere with their quality of life down the road. That's 3 fewer. My wife's a nurse at BJC. That's 3 nurses per day fewer nurses per day who are dealing with a hypoglycemia event now across our system. And sometimes that takes sometimes a few hours, sometimes a whole shift, depending on the problem that's not occurring. And that's when we talked about it, how the video talks about how many more fewer hospital days and the state cost savings. So I think in the new pharmacy PPMI from ASHP, that we need to highlight the role of the medication safety officer and pharmacist outside of what is well known to hospital administrators, that we manage formularies, that we do pharmacokinetic dosing and things like that. I think we need to highlight the fact that quality, improvements in quality have cost savings as well, and are highly valuable. So I think highlighting these successes are very key. And so I want to thank again Cardinal Health and ASHP for creating this award and honoring us. So just in closing, when I sat in on the best practice calls from other initiatives, I remember listening to a doctor from New York talking about fall prevention, and he was just relentless on how he continued to reduce harm. You needed to have somebody at your hospital that keeps holding your feet to the fire and that keeps pushing forward. And so that was a lesson I learned from that call. The other day when we had 31 events and we had 32 or 34 the month before, I called all the hospitals up and I said, this is really almost too good to be true. Is this real? I got to find out, because I'm going to go down here and talk about it. And this is huge. And so I called this hospital who was having 40 events per month when they first started, and there the hospital had 3. And so I called up the diabetic educator who deserves a gold star here, Ramona Deckroden, I'll say her name here. I called her up and I said, is that number real? 3? Did you really just have 3? And she said, yes, and gosh darn it, 2 of them were preventable, and we should have got those 2 taken care of. But the patient came in on a Saturday night, or Friday night, right after I left, and nobody looked at them in time. And I think that's the type of relentless work that exemplifies the effort that we all put forth at BJC to reach the goals that we did. So I want to